Thanks very much, Asia. And hello, everyone. So again, for those of you that don't know me, I'm Elliot Singer, GP partner in Malvern Forest, East London, but Deputy CEO of London-wide LMCs. And I've been asked to talk about QOF and the changes to QOF that's been occurring over the past year. And now, if you've ever heard me speak about QOF before, you'll know a little bugbear of mine, which I'm going to come on to in a moment. But as Asia said, there's 25 million of so-called new money that's gone into this, equate to 18 points. And there's been lots of movement. So there's 95 points that have been retired from one indicator and reassigned to another. And now for the bugbear. The headline is that the QOF point value has increased to £227.95. But this isn't actually quite right, because the only thing that's increased is the contractor population index. And this is the average number of patients in a practice that they say, and that's what they base it on. So it's gone up to 10,295 patients this year. So actually, if we standardise QOF per 1,000 patients, it is, and always has been since 2004, £22.14 per 1,000 patients. It's never changed. And actually, if we look at ASIA's inflation and do the calculator for that, the equivalent of £22.14 in 2004 is round about £40 mark now. So that's how little in real terms, rather, QOF is worth compared to it was 20 odd years ago. So always remember that when we see these headlines about the rise in QOF. This chart, when we share this with you, this is quite useful to have, and it's just considering the way things have been moved across and reallocated from one, and a little table and seeing the new ones. But we're going to break this down into a little bit more detail now. So one of the key new ones is about the obesity work, and we've got two indicators on this. First of all, and this is really important, it's about referral to weight management within 90 days of anyone with a BMI recorded as obese. And then the second point to this is the shared decision making are offered, including the offer of NICE approved medications for management in primary care. Now, this does not, and we're seeking clarity on this at a national level, because some areas are interpreting that as we don't need to do tier 2 services anymore, and the GPs can just be responsible for prescribing all the medication. Please remember, QOF is there to as a performance reward system. It is not there to fund the work required. So a little bit like if somebody else does a blood pressure monitor and we record that in the notes, that still counts towards our points. So the interpretation of this means that GPs need to be the ones prescribing and actively managing it. We are actively challenging at the moment. But this is a workload. This is definitely a workload in there. And one of the things that I'm most certainly noticing in my own practice is patients have heard about this and expect that we're going to be able to prescribe, and not appreciating the NICE guidance and the restrictions on it with the 5 comorbidities and needing at least 4 of those. So we need to think about how we communicate this to patients, hopefully prior to them using a consultation for us to explain it, so that they're not coming in with unrealistic expectations during that consultation. So that's the obesity one. The next big change is regarding blood pressure. And the blood pressure indicators, there's a couple that have been reallocated, and essentially this is now about the sort of 79 and unders, 80s and overs, and the different blood pressure control in them. But key to this is that this is people without frailty. So another take-home message here is that actually get your frailty coding right. So one of the early things you need to be doing in the QOF year is actually looking at those patients in these cohorts and make sure if they are frail, they are coded as such. And if they're not coded as such, because if not, that's going to have an impact on all this data and all this work that you try and do. QOF has, heart failure and diabetes have subtly changed in that it's the heart failure has really caught up with the general practice really, and good quality practice, that we talk about these 4 pillars of therapy. So for the non-clinicians that are listening at the moment, this relates to the patients being on ACE inhibitors, beta blockers, mineralocortical receptor antagonists, and SGLT2 inhibitors. So part of this work is actually making sure that everybody in the team understands that you're doing the searches, you're identifying when they're not, and if appropriate, then you are having the conversation with them to put them on it. Diabetes is more of moving from other codes into the 8 care processes, because we've been doing these things really. This is the BMI, blood pressure, HbA1c, cholesterol management, measurement, smoking, foot checks, the ACR, the urine ACR, and making sure we do the EGFR. So hopefully that's just really rebadging it into here rather than anything actually new. There's been quite a lot of changes to the VACs and IMMs, and I'm going to cover that in a separate section shortly. But this is important, this bit now. This is about the personalised care adjustment, and this is new for this year. So we're moving away from exception reporting. It replaces this and is subtly different, because actually within this, rather than the exception reporting, which takes them out of the register and counting, this is for the particular indicators. So somebody may be excluded, if you like, from a particular indicator, but not from the actual overall disease register. But equally, even if you've excluded them and then this is achieved, it will still count towards that work. And there's, broadly speaking, these 6 reasons for why we can exclude them. If the service is not available, if for one reason or other the patient is clinically unsuitable, the patient decides not to have it. The non-responders are subtly changed, because if they, you need to be trying to invite them on 2 occasions now, except for cervical screening, which is for 3 occasions. You can then call them a non-responder. And there's, it's worth looking at the business rules on this, because if it's a newly diagnosis, you have certain timelines of which you can actually say, well, we haven't had time to do that. Equally with the new patients as well. They can be excluded from that if they haven't registered within the practice within sufficient time. Okay, just moving on for that. Good. And I know QOF has been around a long time, but it's always worthwhile thinking about your approach to QOF, and to think of it as a little bit of a QI project and how you can do it better. So what I'm going to ask people now to do, and if Andre can open up the first of the polls for me, because I just want to ask you a really simple question. How easy is it for you to achieve your QOF points? So I'm hopeful, Andre, you're able to do that. There we go. Wonderful. So nice simple question. How easy is it for you to achieve your QOF points doing whatever system you use? So difficult, quite difficult, manageable, or quite easy. And we will give people a few more seconds. Andre, when we've had a reasonable response, if you can just close up so we can see the results on that one. Hopefully it can be closed now. There you go. So most people find it manageable, but actually over a third of you are saying it's still quite difficult or difficult. Okay. And now there's one more question I've got to ask you before I talk about it a bit more, about the way in which you do it. So bearing that in mind, and if you can open this one, do you just do opportunistic work? Do you do it in the end of Q4? Do you spread it over the course of the year? Or do you absorb it in normal clinics? There may be other ways as well. I appreciate that. And again, just literally a few seconds just to briefly answer that. And then Andre, when you're ready. Okay. So interesting that, you know, almost 3/4 of people sort of do it over the course of the year now, but still, you know, over a fifth of you are sort of doing that thing. And I used to drive me insane, that end of year rush. It's really difficult to do. So as I said, is that what I would suggest to all of you, even if you think it's easy and are really good, is take a QI approach to this. And there is more information available on this, but sort of thinking about the workload, thinking about using your teams, and especially in being proactive in when somebody's invited. Have they had the blood test forms in advance, the urine test forms? Have they been sent the asthma control test? You can use, you know, we use AccuRx to do that type of work on it, so that you really try and absorb this. I really would suggest that you try and think of this in advance, you divide it up, and actually, if you can spread it over the year, it's much more manageable than having to do the end of year. And also, if you do it in the end of year, you don't have an opportunity to make a change and then retest that person to see if they've got into range. So really think about that. And so use this as a bit of a reset. As I said, the clinical pathways for the obesity are really important. That's new this year. Thinking about don't work on the retired indicators. We've all got enough work to do without doing that. Look at your frailty indexes, upskilling the staff, both for the 4 pillars and the 8 care processes. We're going to talk about increasing childhood vaccine uptake and the personal care adjustment. There's just going to leave you with those few tips. I'm not sure whether or not there's any questions, Vanessa or Darren, that have been posted that anybody wants me to try and ask just before I move on to vaccines.
Darren's doing a great job answering the questions as they come up. We do have one from Emma, who says currently there's no local pathway for OB005 referral in NEL. They've set up a primary care service for 25-26, but have paused this since April, and no news on replacement. Do we just wait and at the end of the year code them all as no service available?
So thanks, Emma. And as you know, I'm very much aware of this being a North East London GP. I think at the moment we have to sit back and wait because, as I said before, this is not for us to be doing this work. This is to make sure the systems are in place. We need to be doing safe care. So at the moment, it's maintaining the pressure on the ICS, which I know you are doing, in trying to address this.
Thank you. I think all other questions have been picked up on the chat.
In that case,
if I might just say, thank you, Vanessa. So we are trying to answer them in the chat wherever possible. So can I just gently remind people, we're not all familiar, I know, with the Q&A section, but there's a speech bubble if you click on if you want to ask a new question, and then we'll try and answer them in the chat, or we'll get them to Elliot and the team at the end of each section. Thank you.
Thank you. Right. Okay, as always, I'm running ridiculously over, but I am going to move on to vaccines because it's an important area. And there's been a really important change this year that's going to benefit, I think, London GP practices. London has notoriously had problems because of our population and a migrant population of achieving absolute targets. What they're doing this year is they're moving to actually providing, if you get an improvement from your baseline of at least 5%, that you can earn some QOF points on this. So this is a real opportunity for us. So I'd encourage people early on to look at this. Outside the childhood IMMs, there has been a change in the SFE about the RSV vaccine, and that this is not just all patients aged 75 and above, but those below the age of 75 in care homes. And it's in the MMR now includes the varicella vaccine in it as well, and that's been updated to represent that. The PCN one, we've got Vicky talking a little bit later on about PCNs, but there is, we've got to make sure there's access to both the seasonal and routine immunisations, as well as better collaborative arrangements were enabled. So I'm now going to just talk a little bit about thinking about the vaccine. We all know there's some barriers to uptake that we can't do anything about, those socio-economic factors on the left in that box, but there are things we can do about the way in which we get people to access healthcare and the systems we have in place, and thinking about how friendly our systems are. Recommend this document by the RCPCH on looking at vaccine uptake in the UK. It was from last year, and it's got some really helpful suggestions in it, very much around thinking about your reminders, your recall systems, whether or not you do opportunistic vaccination. If someone's in and you're talking to the parent with that young child there, and you've got a nurse or someone that can vaccinate available, while they're there, can you ask the person to do it? Do they have the capacity to do that? Flexible access. I heard recently about one practice that had a part-time nurse on a Monday afternoon and wasn't hitting their targets. Well, that Monday afternoon is during school hours. It meant people taking out from work, from school, etc. It means it's really difficult for people to access it. So think about where we've got the access there. The extended access appointments, can you utilise those? Outreach clinics. We've had some great things with people going into local community centres, into various sort of even religious centres and things like that, to actually do the reach out and vaccinate. And as I said, the one-stop clinics, if you do have a health visitor in your practice, in your health centre, can you coordinate so that you put on a vaccine clinic alongside the work they do? And as so much of what we do in general practice is about relationship-based medicine and the personalised engagement. So actually, when you build a relationship with the parent and that child, then actually just softly, you know, reminding them about the benefits of vaccinations and why you want to do that. Because at the end of the day, you know, yes, there's payment associated for this, but we're doing it for a really important reason. And the primary prevention here stops morbidity and mortality. So apologies for racing through that a little bit too much, but as I said, it's a real opportunity to improve from our baselines, and I really would recommend looking at the RCPCH document because it's got some really helpful tips on things you may wish to consider to put into your practice to help you along and improve your access. So if there's any questions on vaccination, happy to take them. If not, I will hand over to my colleague, Vicky Furlier.